Hi, Warrick Bishop here. And if you're listening to this on my podcast or videocast station, my routine communication, then this is a special recording. I've put it together for the paramedical people, that's nurses and medical students who are part of the Healthy Heart Network program. I try and do this a couple of times a year, and I'm going to share it not just with the paramedicals, but also with the broader Healthy Heart Network community. What I will do is share my screen. So those who are listening to this on podcast, you'll just have to imagine. I'll try and describe so you're not being left out. For those who are watching this as a video cast, it will be self-explanatory. So bear with me. I am going to share screen, talk about falls prevention, which is absolutely huge. Preventing falls, reducing risk, and enhancing quality of life. It's a really big deal. The reason why I'm touching on this is, for those who are not aware, April, historically for the last few years, has been an awareness month for falls. If we can improve people's balance, strength, we can reduce risk of falls. And this is super important in the older population, particularly as the population ages. We really want to embrace increased physical activity. We want to keep people socially connected and maintain healthy diets. All these things will reduce risk of falls in the elderly. Well, what is healthy aging? I tend to use the term myself, health span, but people also use the term healthy aging, and it's the process of developing and maintaining functional ability that enables us to continue to do the things we want to do in older life. And there's multiple things that play into this. On the slide that I'm showing, you can see a Venn diagram with multiple circles. They're all overlapping each other, and they include such things as mental health, physical activity, cognitive activity, good nutrition, social engagement, and all those combine and overlaying all the intersecting segments for prevention and healthy aging. And it makes perfect sense. If we're not looking after our mental health, if we have declining cognitive activity, if we're not keeping ourselves physically strong and we don't have good nutrition, we're in a lot of trouble. And there's so much research supporting the benefit of social engagement. Well, one of the fundamental things that we know is exercise, almost of any type, has been shown to reduce the risk of people falling. So if there is a single take home for you, or for you to share with someone you love who you think could be at risk of falling, that is that there is a 23% reduction in falls risk with almost any sort of exercise. It's probably sensible to build that exercise up gradually. You don't want to be taking an elderly grandmother who's been fairly immobile for a long period of time and decide to start off with a 10-kilometer fun run, but build it up. Exercise is critical. We know that because there's good review research that pulls all that together. Randomized controlled trials looking at over 20,000 people in multiple countries worldwide, with exercise reducing rates of falls by nearly 25%. And reducing the number of people experiencing one or more falls by 15%. This is really significant. We'll touch on that even more later. Well, what are the sort of things that people can do? Well, balance and functional exercises are important. They could be home-based or in centers with support. Resistance and strength exercises, again, these can be home-based if you've got the equipment at home. These can also be done in conjunction with balance training and done through organizations or centers. These really do benefit all types of falls rates when done. And Tai Chi, which can engage people in classes, which has the added benefit of not just movement and balance, but social engagement and mental health. So balance and functional exercises, particularly if they're undertaken for 3 hours per week or more, are particularly effective. There is a huge cost to falling. It is one of the leading injury-related causes of death in older adults. It's a leading cause of hospitalization in older adults, we're talking just over 40%. 30% of people suffer injuries requiring medical treatment. That's a huge number. 10 to 15% of falls are serious injuries like a fracture. So when we look at hip fractures, for example, and you may be able to recall this from people you know through your own experience, 50% of all hip fractures are discharged to nursing homes. 25% never regain pre-function or pre-fracture mobility, and 25% of those people who suffer a hip fracture will die within 12 months. These are staggering statistics. When we look at what causes men and women to fall, this is a summary of 704 women in particular, aged between 65 years of age and 99 years of age. And you can see, if you're looking at this pie graph or pie chart that I have on the slide, that the biggest component to falls are trips, followed by balance, followed by slipping, followed by unsure of what happened. Now, trips can be something as something as apparently innocuous as a corner of a rug curled up. It could be a cat or a dog. Then we've got issues like weak legs, dizziness, and faintness. But slips, trips, and balance are huge, and it's so important that people keep an eye to what might catch them out when they least expect it. When we look at the medical problems attributed to falls, we can look at the cardiovascular circulation, so problems with the electrical system of the heart perhaps missing a beat or not beating properly, going slowly, or low blood pressure, causing about 17%. Visual impairment, as high as 60% of all falls attributable to visual impairment. That fits with trips. Decreased lower limb power, that could be associated with strokes. Nearly 30% of falls can be attributed to that. Peripheral neuropathy means nerves that are not working in the feet in particular, so not feeling properly and therefore not having a normal balance. Nearly 20%. Measured strength and balance impairment. Now that overlays other things, including frailty. Up to 72% of people with falls will be identified with that strength and balance impairment. Now I'll come back to that because I have a specific interest in that space, and I'll talk about something called osteostrong right at the end. Cognitive impairment and depression both feature really highly in the associated medical conditions linked to people who fall. Undiagnosed malignancy is a small percentage, but still not unheard of. So this is a nice schematic or diagram pointing to the different ways that components of, say, medical condition or medications, etc., can feed into a falls possibility. For those looking at the slides, it's perfectly obvious. For those listening, I've got a slide in the middle with falls as the central feature. Feeding into that are a number of, if you like, boxes, and each of those boxes I'll run through. The first is medical conditions, which includes things like stroke, incontinence, Parkinson's, and dementia, all feed into falls. So does medication, polymedication. So people with multiple medications can run into problems. People on psychoactive medications, people on the diazepam and other sleeping medications can all have a change in their sensory neural balance, all feeding into falls. Sensory, motor, and balance issues, which includes muscular weakness, tied in with frailty, reduced vision, super important, touched on that before, reduced function of the nerves in the periphery, we call that peripheral neuropathy, slow reaction time, and impaired balance, so huge as well. And we see people as they age lose that quick response, lose that balance. The environment's incredibly important. Poor footwear could be a cause of its own. Hazards in the home, like a turned up rug, like a foot cushion left in the middle of the room and not put away. Cats, dogs, external hazards like children, for example, and even putting on the wrong spectacles. If you pick up your partner's spectacles and you've got the wrong visual aids, they could be detrimental rather than helpful. And really important, psychosocial and demographic, advancing age, a falls history, depression is incredibly important, living alone, problems with undertaking activities of daily living. Females seem to be at greater risk Not sure why, perhaps because we've got more older females, and that ties in with age and frailty. And importantly, inactivity also feeds into that risk of falls. This is a mobilization guide and really, I think, speaks to the common sense of how we have to deal with people depending on where we assess their risk of potential fall and whether they need assistance, standby assistance, supervision, or if they're independent. And therefore, the way we deal with those people is going to be quite different. The independent person obviously needing really just care and attention to their environment, for example, versus the person who needs assistance regarding, say, bed mobility, to sit, to stand, to walking and toileting. So your support for these individuals will be tailored to their mobility level, independent, requiring supervision, standby assistance, and full assistance. So when we talk about making sure people are going to get home safely from hospital, it's important that there's a discharge planning process which understands that falls is going to be a significant component of any discharge risk and strategy. So patient, carers and families all need to be across those risks, but so do the GPs. And if patients are going to residential aged care, of course, that needs to be pulled in to that conversation as well, as would things like district nurses and other health providers such as physios or exercise physiologists. So safe exercise at home is a great resource for patients post-hospital stay to try and maintain them and keep their risk of falls down. It's very important for people to maintain social connection, because without social connection, they really won't hold on to the requirements of maintaining strength, engaging in programs, and really without social engagement, there's a loss of quality of life, there's a loss of mental function, happiness drops off, feelings of belonging drop off, obviously, and all our research, and this is from a fairly long-running study, I think it's multi-generational, called the Harvard Longevity Study, has really demonstrated to us that social engagement is key to long, happy lives. When they did look at the data, there were two things that defined longevity in association with happiness, and those two things were good health and good relationships. And when they drilled down to that even further, they were able to say that the good relationships were a significant driver to the good health. So maintain social connection. And there's lots of ways you can do that. There are centers, there's all sorts of resources available. As part of trying to keep strong, it's incredibly important to maintain good eating. And this is critical. It is not uncommon for people as they age to perhaps not bring the same level of focus or attention to their cooking, particularly if they're living alone and they're looking for easy and convenient meals. It's so important to make sure your protein intake is adequate, because if you are trying to maintain, say, muscle strength, which is a huge component of falls, if the diet is not right, then the opportunity to maintain muscle strength is going to be diminished. So muscle mass, muscle strength, we call that sarcopenia when the muscle weakens. Frailty, we see. These really need to make sure you're eating properly at the same time as exercising to get those benefits moving together. One without the other doesn't work. You can't make a cake without eggs. So there's resources to try and support people looking to find ways to engage in healthy eating. But this is something that family and friends, together with local doctor, can engage with a patient about to ensure that it's really being addressed properly. Lots of guidance for eating well. When I did some research around this process of falls, there was resources like this image I've got on screen at the moment, which is a healthy aging challenge. Now, for those not listening, I've got a little calendar that's mocked up, and it marks off diet, exercise, and socialization as the three things to tick off every day. And this little 3x3 healthy aging challenge is something that people could perhaps print off from the internet, put on their fridge, and tick that they've eaten well tick that they've done some exercise and tick that they've had some social engagement, with the challenge to be able to do that every day. Makes a bit of sense, and if it supports someone in that journey, why not? So there are plenty of resources available. I actually found that New South Wales Health had some really good resources, so do a bit of searching and look for anything that you think could help in that space. Remember, some of the key elements are around, well, we talked about key elements, particularly around eating well, exercising, and diet, and that's mainly for people in the community. But in institutions, there's a number of really important components that people need to be aware of. And because I know there'll be junior medical students or medical students and nurses looking at this, I think it's important to touch on falls risk in institutions, because if someone goes into hospital with a pneumonia, for example, and as a consequence, they suffer delirium, climb out of bed and break the leg, then the complexity to that episode of care is extended and enhanced enormously. So when we look at people in institutions, we need to be aware of a cognitive assessment, a delirium screen, whether there's a role for bed rails or not, or the bed being low. Visual checking could be incredibly important about orientation and knowing if the patient knows where they are, let alone what they're stepping past or through or on. Because of that disassociation some older people certainly have when they're moved to hospital settings. Lying and standing blood pressures are super important. Medical review and medication review is super important. And then understanding if those identified high-risk individuals need some sort of specialized or targeted observation. I'm going to wrap up talking about OsteoStrong. I have a personal interest in this. I became aware of the technology in relatively recent time when I was recovering from my own health journey. I had open heart surgery and was looking at ways to maximize my recovery, and I came across this wellness center, which is really leading a revolution in natural bone health and strength. And as a consequence, my partner and I bought a franchise. It's called OsteoStrong. It's across Australia, and there's about 150 to 160 centers across the world. So it's potentially relevant to many people. The reason why I want to touch on it is of the issues I spoke about. I flagged the problem of falls being related to frailty and fractures, and OsteoStrong could be a solution. Now let's talk about fractures first. We know bones peak in any individual around 30 odd years of age, and then bone mineral density drops off gradually, more so for women than men, generally because of the menopause. It's really important to remember, because as bone strength drops off, muscle strength drops off as well. Remember, they move together. I've covered some of these stats, but I'll touch on them again. Approximately 40% of all women and 30% of all men. This is a lot of people will have an osteoporotic fracture in their lifetime. I touched on the hip fractures before, but I didn't give you all these stats. 20% of women, that's 1 in 5 women over 60 years of age, will fracture a hip. Half die within 2 years due to complications. Half will end up in institutionalized care. 2/3 of men over 70 years of age who have a hip fracture will die within a year. What is this telling us? It's telling us that if you have a hip fracture, you're deconditioned. If you're deconditioned, you're frail and you've got weak bones and you will not recover. It's a bad story. It is not a extending health span. So here's something that's super important about OsteoStrong. What we know is if we can become metabolically deconditioned as we age, we can actually, to a large degree, recondition, and that's what we're able to do through OsteoStrong. It started by a biomedical engineer called John Jaquish, who actually designed the equipment for his mum, who was told she had osteoporosis, and she didn't really know if she wanted to go on medication or not. And her son leapt to the rescue and devised a number of machines to osteogenically load his mother's skeleton. That's upper body, lower body, core, and spine. By doing that, he has really been able to create 4 standalone machines, which we hold in center Our members come through, they spend about 10 minutes to 15 minutes once a week, therefore not taking up a lot of time, but just once a week with one of our coaches going through this particular process and delivering a one maximal rep stimulus to the musculoskeletal system. In only 18 months, John Jaquish's mum had reversed her osteoporosis. Well, we've known since almost the turn of the century, and that's the 1900s century, because of a researcher called Wolf. We knew that there's an interaction between loading the bones and the response of the bones, such that if you make the bones work hard, if you do gymnastics, or if you're an elephant, or if you lift weights, you'll get thicker bones. If you don't stress the bones, if you are a swimmer, if you're a cyclist, if you're a blue whale, your bones will not be as strong because that trigger is not there. Nice thing is, if you increase the strength of either the muscle or the bone, they move together, and so do tendons. I won't dwell on osteoporosis, but we do know that osteoporosis is based on an average 30-year-old of the same sex, and we look at osteopenia as down to a 2.5 reduction compared to, or standard deviation from the norm, and osteoporosis is less than 2.5. Really importantly, for those who can't see this slide, it's a reminder that over our lifetime, our bone mineral density drops off around about our 30s and can be worsened by lack of activity and hormones. To build bones, we really need the ingredients of a cake, and you can't ignore one or two of the ingredients and expect the right outcome for a cake, and nor can you if you want to build your bones, where you need a healthy diet, you need active living, you need certain minerals and vitamins, including obviously things like vitamin D and calcium. Drugs can help, but some drugs can be a problem. And what we're finding more and more is you need that stimulus to keep bones strong. That's called osteogenic loading. We've got research that tells us if you don't load the bones enough, if you don't actually have a prescriptive amount of loading for the bones, you may not get the result you need. And for the femur, you actually need 4.2 times your body mass going through your femur to make it lay down new bone. That's pretty hard to achieve. You've got to jump off a fairly high chair to jar the body, which carries a bit of a risk, or you need to run at about 10 kilometers an hour, or lift significant weights. All these are pretty tricky. The nice thing is, though, that the machines that Dr. Jaquish has produced allow us to load those bones, and we've got good evidence of demonstrating improvement in bone mineral density in as little as 6 months, both in the hip and the spine. And we do that really effectively. In fact, better than the drugs which are commonly used, in particular the bisphosphonates and the anabolic drugs. So it's a potential solution, and we've had that confirmed not only in trials run by Jaquish, but in trials that are run by a third party. Really important to understand that when it comes to falls, balance is key, and balance is a whole neurological process, including the brain, the cerebellum, which is really the lower part of the brain, and the peripheral nerves. Part of this requires neuroplasticity for the body to relearn, and through our centers, we vibrate people before their sessions to stimulate, if you like, and generate neuroplasticity, refiring, rewiring, and relearning the balance processes. Really nice thing is, through our OsteoStrong centers, we've got not just anecdotal evidence of some of our members improving with their balance. I had an old guy the other day who was happy to tell me that he could now stand on one leg and pull on his trousers, but we've got research data that supports that even after as little as 5 sessions, so that's just over a month of attendance, only once a week, we can see improvement in balance in the vast majority of people between 50 and 80 years of age. One of the things that I think we're all aware of these days is muscle weakness, and weakness is frailty, and frailty is really the way people fade away, and I see it as a very sad and disappointing way for us to end our life. What we know is if we can strengthen the muscles, we can keep people functional longer and push frailty away. We've got some nice research from OsteoStrong centers in the United States where they've taken 500 men and women, average age 52 years of age, and put them through their program and have measured several 100% improvement in strength over 3 to 4 years. Now, that's almost incomprehensible. And this is for people who are about 50 years of age. Almost every intervention in medicine offers a greater return on investment the sicker someone is. So if you take someone who's really well and who doesn't have a headache and you give them Panadol, you get a very poor positive result from that study because they're not that crook. But if you take someone who's got a really bad headache and you give them a cup of Panadol, you get a great response. Why am I telling you that? Well, this strength data tells us if we take those older people and we can engage them in this program, there's no question we will give them an even better upside. So the problem, fractures, falls, and frailty, the solution could well be osteogenic loading. I'm going to wrap up there with a number of acknowledgements, and I really want to thank the people who put together so many resources on the internet for falls because it's such a big deal. It is my privilege to have shared. For those who are on the so-called live, which I've recorded, I apologize, and I will endeavor to be live the next time. I think we do those quarterly. Please, if you've got any queries or questions, drop me a note so I know what I could speak to that would interest you. It would be my privilege and pleasure. For those who are listening to this as part of a standard podcast or videocast subscription, I hope you've enjoyed it. I've covered a lot of stuff. I think it's super important, and I'm going to leave it there, but I'm going to wish you the very best and hope you live as well as possible for as long as possible. Take care and bye for now.